recently we had two studies that essentially expanded the treatment window from 0 to 6 hours now all the way to 24 hours. So prior to these studies, all the treatment decisions were solely based on time with some minimal imaging selection criteria. So what you did in the DAWN and DIFFUSE 3 trials was to use imaging, in this case advanced imaging, either use CT perfusion or MRI, to find patients that had small strokes but had high clinical severity. So their presentation, they look really sick, had many clinical deficits. And then we saw that in these patients that had a mismatch between a bad clinical exam and a small stroke on imaging, we could still achieve a fair amount of benefit from treatment and higher rates of good outcome at 3 months, despite treating them beyond 6 hours. In fact, the patients that were treated later in the window, if anything, they had more benefit than the earlier treated patients. However, these are all patients that had this mismatch, and that's a very important notion, is what these trials have done is they expand the window of opportunity, but the amount of patients that will qualify for the treatment drops over time. So now you can find a few patients, even in the later window, that will benefit, but your chances of benefit will be a lot higher if you come to the hospital in the earlier phases. So time is still brain. We just open up the late window for certain patients, and you have shown they can still benefit. Based on the findings of DAWN and DIFFUSE 3, so we had 2 trials that essentially showed the same thing, our ability of using advanced image, treating patients at a later phase and having a benefit. So based on that, the American Heart Association guidelines were updated to include patients in the 6 to 24 hour treatment window. So the guidelines are strict to the criteria that were used in the clinical trials. That's just how the level of evidence works, okay? However, there is a different way of looking at the data, and as opposed to essentially following what was done in the trials, more like understanding the meaning of what was done in the trials. For instance, here like in South America and Latin America, actually outside Europe and North America, very few centers have access to the high technology that was used in these trials with CT perfusion and expensive softwares or MRI in the acute phase. So it becomes important to understand that yes, the advanced imaging was used in the trial, but if you don't have access to advanced image, it doesn't mean you can't treat those patients. You just have to use your best judgment, and based on a big deficit on clinical exam and a good imaging, on the imaging that you have access, which is typically a non-contrast CT and a CTA, you can still make a good decision in terms of treating those patients. Approximately in the DAWN trial, approximately 55% of the patients, they had wake-up strokes, meaning they woke up with a stroke. So the problem is we don't know when the stroke took place. So even though you were saying you treat these patients late, maybe the stroke woke them up, or the stroke just happened like 1 hour before they woke up, and therefore you are not really treating late patients, okay? So the wake-up population was one of the populations you treat. You also treat patients that had unwitnessed strokes. They had a stroke not upon awaking, but at some point, but there was nobody to actually see when it happened. And then we had patients that actually had witness onset strokes and then were treated late. So the inclusion criteria was time from last seen well at the baseline to the randomization, to the imaging and randomization for the trial, okay? The wake-up stroke patients and the unwitnessed patients, we just don't know when the stroke happened. But you had the witness patients that you actually know that in fact the stroke has happened more than 6 hours. in relation to the treatment. And it turns out that the patients with the witness onset, those that we know have had the stroke for longer, had the highest benefit numerically in the trial. And they actually did better both in the thrombectomy arm and in the control arm, as well as the difference was still the largest one. And the reason for that is probably because, again, those are outpatients in these trials, okay? The vast majority, they have small strokes. So if you have a small stroke and you have a longer time of ischemia, the only way that can happen is if you have better collateral flow, because the collateral flow keeps the brain alive for longer. You slow down the pace of the stroke progression, okay? And if you have better collateral flow, then you have better outcomes. And that's the justification why actually patients with witness strokes did even better than patients with wake-up strokes. So that's one point. The other point is approximately 40% of the patients in DOM had time from symptoms first observed, like maybe you are a wake up or you are an unwitnessed stroke, but now I know you have your symptoms now. So from that point you were first observed to randomization. About 40% of the patients in the trial had that time longer than 6 hours. And then when you compare the ones that had time of symptoms first found longer than 6 hours versus the one that had time less than 6 hours from the time they were observed, the ones with longer time numerically had a higher treatment effect size as well. Again, pointing out that time is not everything. Collateral flow has to be introduced in our equation of the decision making when you are thinking about selecting patients in stroke. And patients with collateral flow, they can benefit even at a later time. But again, when you look at an overall population, the chances of you qualifying for treatment will be a lot better early in time, and any patient, even the patient with the mismatch and good collateral flow, if they are treated faster, they will do better. So time is still brain. And that's what I was trying to make, the point that sometimes that's not available everywhere, and it shouldn't be an excuse not to offer patient the treatment. Because you can diagnose a small stroke even in a non-contrast CT. Maybe it's not as reliable, but it should be good enough. And not treating those patients is just a bad idea. They do terrible without treatment. I think we know that as a fact now from Down Diffuse 3, that if you have a bad clinical deficit and you don't open up the blood vessel, you're going to have a bad outcome.